So, good afternoon from London. My name is Dr. Manish Raval. I'm presenting to you from Moorfields Eye Hospital in London. I've called this Working Together for Safer Eye Surgery. I was very touched by Hunter's suggestion that I had some special secrets that I could share, but I think we all have a lot of knowledge that we will be able to share. So, let's get underway. I can declare no conflicts of interest. My experiences as a UK-trained anaesthetist. I originally trained through London, through the University College London Hospitals and the Royal Free Hospitals. I performed a clinical fellowship for a year and a half at Melbourne in Australia at the Royal Melbourne Hospital. I've been a consultant now for almost 20 years. Initially, I worked at Guy's and St Thomas's hospitals for about 10 years, and now I'm currently full-time at Moorfields Eye Hospital. In addition, my other professional role is I'm a Royal College examiner for the FRCA, the Fellowship of the Royal College of Anaesthetists. In terms of global work, I volunteered and worked with the Royal Australian College of Surgeons in Timor-Leste. I've worked with Mercy ships in Sierra Leone, and the biggest part of my voluntary work has been with Orbis. And I feel very, very akin to their ethos of how they teach and how they want to propagate safe surgical practice. So there's a number of countries where I've worked, and all of them have taught me more than I've probably learned anywhere else, I should imagine. So, why have I picked the content that I've picked? It's items that I recognize as important, but it's also subjects that have been suggested to me by Orbis eye surgeons who are colleagues of mine who I've worked with as well. And one or two, I think, have also come out through topics proposed by registered attendees, at least in the early days when they were first kind of given the opportunity. So if you've given a question or a subject matter that's come later, I may not have covered it in this, but I hope to cover it maybe in the questions and answers. As of now, let us begin. And I think the best way to start is with a bit of interaction, because otherwise it's just about me talking and not enough about us all thinking together. So the first question I want to sort of bring to you is about your opinion on a certain aspect of practice. So most of this presentation is going to be about my opinions, and I know that you will hold opinions that are strong, that adhere to what you do, and reflect your practice and your knowledge. So I would like you to share them as much as possible. So let's have a look at the first question. Do you use the WHO surgical safety checklist? Sorry, I've jumped forward there, I shouldn't have done. And I'd like you to be as honest as you can. So yes, in full, you do the brief, the timeout, and debrief always. You do some part of it regularly. You do some part of it occasionally. You've tried to do it and just given up, or you've simply never heard of it. What's reassuring about this is most of the people out there have at least participated in the surgical safety checklist to some extent. What's worrying, though, is a good third have never heard of it. And without really spending a whole lecture upon this, which is very easily done, I would suggest we talk about why it's beneficial. There's a good 30% of you that probably realize this already and are performing it in its entirety. And I really respect and applaud you for that. But let's try and share the reasons why the rest of us think it might be relevant. Andy, I can't close that slide and move on. That's thing. Thank you very much. My belief is, when this was first introduced, it was an idea that kind of had essentially use anywhere and everywhere in the world, which is quite unusual for medical advancements. Often we are very much predilected upon what resources we have and what we can invest. But this is an excellent return on your investment because it takes very little. It takes engagement, it takes a recognition of a process, and it takes a team working together. There is evidence, proper randomized controlled trial evidence that suggests that mistakes are reduced by using a system such as this. Any system will reduce mistakes, but what this system allows you to do is adopt a system that's globally recognized, and as a result, you will be supported, essentially by the WHO, to invest in producing this as a local checklist that you can then execute on a regular basis. The idea being that right from the outset, the team introduces itself, everybody has a name and has an allocated role that is then known. As a result, there's better communication. People are likely to talk to each other, and as a result, less likely to make mistakes where they try and cover up their lack of knowledge or their lack of understanding, or their lack of awareness of what's going on, they will be more inclined to ask, and that helps enormously. The reality is mistakes happen, and we need to sort of create methodology to stop that from happening. And as a result, less problems with death, less problems with problems with morbidity in terms of complications. It also has this very useful thing where it positively recognizes all members of the team. At the timeout, everybody's involved in recognizing that the patient is there for a particular procedure, needs particular instruments, and the correct side is being done. Such a common error in lateralized surgery, such as eye surgery, and yet there is no easy way of stopping this. Even this surgical safety checklist has had failures in doing this, but this brings you much closer to preventing that from happening. And recognizing the value of your nursing colleagues who are more likely to be able to sort of speak about the patient is a very useful part of this. The other thing about this is when you are creating your list structure at the start in the brief, you have a better list management strategy. You're less likely to keep patients starved for long lengths of time. You're more likely to prioritize medical patients that need prioritization, and you're then going to get a better flow through the list, less stopping and starting. This has been endorsed by all the major health providers, including Orbis, and so it's essentially feels like a no-brainer that people should try. For those of you who've never heard of this, I'm sure through Orbis you can get more information and you can start practicing this straight away. But that's about as much preaching as I can do about this, because this is an enormous subject and I'd love to tell you more, but we want to move on and talk about some other aspects of clinical care. So I have another question for you. Now, this is a specific medical question with a view to you looking at your medical practice in a particular situation. So not uncommonly, patients will present for eye surgery either as known hypertensives or as a newly presenting hypertensive. So let's look at this particular individual. A 67-year-old man with known hypertension presents for elective cataract surgery. He has documented history of heart disease, stroke, and diabetes, it should say. He has no documented history, sorry. He has taken his normal morning dose of amlodipine, 5 milligram, 1 hour previously. But his blood pressure is being recorded as part of his standard preoperative observations, and it gives you the following values. Systolic of 181 and a diastolic of 92 millimeters of mercury with a pulse rate that's regular at 84 beats per minute. So known hypertensive, that's the only condition that he's suffering from, and he takes one medication, but that's his blood pressure, and he's about to have cataract surgery. So do you proceed? So just using those facts that I presented to you, yes, you proceed because there's no concerns. Yes, you proceed, but this is not a case for training and you should get the most experienced surgeon to do it. Yes, give him something to reduce anxiety first, a simple oral medication like a benzodiazepine, and then proceed. Yes, but let's actually actively lower his blood pressure with whatever medication you are most comfortable and familiar with, and then go ahead with the surgery. Or no, patients should be sent away. They should be given instructions to start additional antihypertensive medication, monitor their blood pressure, and return for surgery after 6 weeks. There's clearly many other alternative pathways, but try and pick one of those that's closest to your opinion. Okay, so very interesting again, because I think I'm going to clash with the global opinion out there, which I'm quite pleased about in one respect, because it goes to show that you are essentially being very safe medical practitioners. More than, I don't know, almost 2/3 of you are wanting to either defer this to control blood pressure or to control blood pressure here and now before the surgery. Let's discuss that in the next few slides. So, blood pressure. It's a global concern. Up to 80% of adults aged over 60 are known to maybe either suffer from blood pressure with requiring medication or are being monitored. That's almost 1 billion people. We have thresholds that have been defined by virtue of the fact that they're associated with target organ damage. These are numbers, simply. A systolic greater than 180, a diastolic greater than 110. Clearly, other factors would also contribute to making a risk greater with lower blood pressure values. Patients with diabetes, known ischemic heart disease, known stroke. But these are the values we use to guide us as a way of knowing that there is likely target organ damage. There's an increased risk associated with hypertension. Adverse medical outcomes, such as cardiovascular, patients can suffer from ischemic heart disease, have angina, even suffer a myocardial infarction during surgery, or neurological problems, where they may even have a stroke. And these things can complicate the perioperative period. Clearly, as people working in and around the eye, you're very concerned that there may be a surgical complication which isn't going to involve sight-threatening bleeding. And what's the sort of background to this? Well, high blood pressure, there's going to be increased fragility of ocular blood vessels. Sometimes the side effects of the drugs that you treat blood pressure with, and alpha blockers, doxazosin, are very common in resource-poor countries, can result in making the surgery difficult with a floppy iris. Hypertension in itself is associated significantly with a more capsular cataract distribution, so again makes the surgery more challenging. And clearly, anybody who's got hypertension and has it for some time has got associated comorbidities and acute end organ damage, maybe renal dysfunction, maybe some level of ischemic heart disease. But is there any evidence that this is going to cause problems in eye surgery? And this is the important thing. Evidence exists for other types of surgery, and we often extrapolate that evidence to eye surgery. But we have to be careful about doing so, because clearly those patients are having surgeries where the intervention in itself is much more likely to precipitate blood pressure changes, lability up and down, as well as have much more consequence immediately for the surgery itself. So there have been several studies over the past 2 decades, but little or no evidence at all of systemic problems. My most intriguing study that I found was a Dutch case series where they looked at 4,000 patients, and they decided that adverse cardiac and neuro events were very, very rare. So whatever the blood pressure of the patient at presentation, they went ahead and had surgery, and there were no recorded systemic complications. In the UK, a similar case series of over 740 cases were done back in 2010, and again, resulted in no adverse systemic problems. The problem with some of these studies is treatments have often been given which have not been picked up by the researchers. So people may well have had their blood pressure treated, and that way well have permitted them not to have a problem. We just don't know that. But across all of the studies out there, most of this comes from those types of surgery which I don't think are relevant to eye surgery. And I think you have to be very careful to interpret the results from those that should then influence an involvement in an eye operation. The biggest concern I'm often presented with when a surgeon says to me, I'm unhappy about that blood pressure, I suspect we may risk suprachoroidal hemorrhage. Interestingly enough, looking at that, a British study looked at all the suprachoroidal hemorrhages reported over the course of a year and a half, almost 100 cases, and in none of those was blood pressure a significant risk factor in the patient. The only time I found any evidence was in combined glaucoma surgery and cataract surgery, where there is a delayed risk of suprachoroidal hemorrhage when there's raised blood pressure. So a very small niche group. Now, what are the practical considerations? So I'm sort of suggesting maybe we don't need to worry about this. I don't think that's entirely true. I think we should be aware of patients' blood pressures, and we should be very considerate to what we can do to manage them. So the exacerbating factors: is the patient anxious? Have they missed any of their treatment that they would normally treat? Often patients will omit drugs on the day of surgery, and that can have consequence. Have we been excessively generous with phenylephrine drops to dilate the eye? Is the patient in pain? Is the patient cold? But on the day of surgery, a blood pressure recording is a blood pressure recording, and that can cause you concern before starting the surgery. What most guidance would suggest, though, is look at the measurements made in primary care. Now, I accept that that's not always available, but these values are much more reliable. So the trends that the patient displays over time, over the last few months, are much more reflective of their normal blood pressure. And the slight rise in blood pressure that's associated with the anxiety of a surgical event is not relevant. If you are treating blood pressure, though, remember that treatment takes time, and you do need to wait for that to take place. So it takes about 6 to 8 weeks for regression of endothelial and vascular changes. And it's especially important when there are accompanying risk factors. You then should be treating blood pressure ahead of surgery if there are other risk factors present. My concern is those interventionists who are talking about, I think a third of the group said they would acutely treat the blood pressure with a medication. It's very hard to know what medication is probably the ideal. Given the fact there'll be variation across the world in terms of what's available, this will be different across different centres. But it can be hazardous. You have to really carefully consider the drug you're going to use in terms of its longevity of action. Are you going to send the patient home with a blood pressure that's suddenly much lower than it should be, and they can have some other consequence that's not eye-related? Or are you going to find yourself treating with agents that have interactions with drugs that they're already on that can cause problems? And all of these things can make that need to treat blood pressure in the time just before surgery more challenging, more problematic than actually just recognizing this blood pressure may not cause surgery a problem. So just emphasizing that again, measurements from primary care are more useful than those taken admission. So this is why we in Moorfields insist on knowing that the blood pressure as recorded by the GP, and we'll often ask patients to get that information if it's not always forthcoming from the GP itself. Where blood pressure is within 20% of that baseline, so what the blood pressure measured in the primary care situation, unless it's highly severe hypertension, systolics well over 200, diastolics well over 110, those are the only situations we'd postpone and try and treat the blood pressure with medical guidance. But if it's within 20% of the baseline, so even if the patient's baseline is 170 over 105, or within 20% of that, we would be inclined to carry on with surgery. Because one of the problems we have is there are so many consequences to cancelling surgery. There's the psychological problems for the patient, the social situation. They may have traveled a long distance. They may have stopped themselves working. There may be financial problems related to it. And at least in our country, there are waiting lists that make people very, very, very stressed if they feel that their surgery is not going to be done when their opportunity arises, and they're going to be put at the back of the waiting list again. Now, this is very much opinion-based, as you can see, because although I've quoted evidence to you, I'm sure it's possible to find evidence that counters that. The fact that there is no clear evidence in either direction really does leave us in the unknown here. But whatever your unit chooses to do, I think you should have a really coherent and consistent policy. And that's one of the challenges we face in a large hospital like Moorfields, keeping the consistency and ensuring all anaesthetists and all surgeons work to the same rule book. There is always individual opinion that's ultra-conservative or less so, but we need to bring ourselves together and work to a consistent rule book, and that way patients are treated fairly. Moving on, I'll give you a break to gather your thoughts, and then we're going to talk about another patient situation. Again, I want to get your opinions on this. As I said, opinions are really important. So on this occasion, we have a 79-year-old lady who is frail, and she presents for cataract surgery, suffering from bilateral brunescent cataracts. She shows signs of early dementia, but is still able to give informed consent for the procedure. She takes regular medication to treat Parkinson's disease and is well controlled with no resting tremor. In addition, she takes oral medication only for type 2 diabetes, and her blood sugar level is 63 millimoles per litre. It's a relatively well-controlled diabetic situation. She's able to mobilize independently, and she's able to lie flat. Now, she's feeling anxious about the procedure as her vision has gone down really badly in the last 6 months. And for that reason, you're considering sedation. You know her surgery is tomorrow, and there's very little else you can do to improve the situation here and now, but you think sedation may help. So, here's another poll. Do we think that the instructions we give her is that she must have absolutely no oral intake overnight until post-op, as this is the case with all surgery? Or do we think she must have nothing to eat and drink overnight except for her normal medication? Or she must be nil by mouth to food and medication for 6 hours preoperatively and nil by mouth to water for 2 hours preoperatively? Or do we think she may eat and drink normally and should take all the regular doses of medication? Or do you think this is not relevant to you? You don't make this decision. You're not involved in this process of counselling the patient about their fasting status, and you wouldn't get involved? Share your answers with me. So, very good spread of answers here. The largest portion have gone to essentially say nil by mouth to food and medication for 6 hours pre-op and nil by mouth to water for 2 hours pre-op, which is a very standard preoperative guidance. This would be uniform for almost all types of surgery where a patient will be having a general anesthetic and has been validated by experience, if not really evidence. We still don't really know as anesthetists what the ideal starvation times are. Things have moved on dramatically, and we are now feeding patients with carbohydrate-rich drinks before major surgeries to improve their outcomes. But we're talking about eye surgery now. Personally, I am tending towards the eat and drink normally and taking all her regular doses of medication. That is my personal opinion on this, but I can see that somewhere along the way, there are certain criteria that may reflect the approach of a whole unit. And it may be the way you work, you share the ward, you share the preoperative assessment unit, you share the delivery of surgical services with a whole bunch of surgeons, and complicating the instructions given to patients for eye surgery as opposed to orthopedic surgery, as opposed to general surgery, may cause more difficulty than it's worth. I see that, and I wouldn't be able to argue against it. But I would say that in eye surgery, we are in a unique situation. So why do we create this nil by mouth fasting strategy? It's definitely considered to be a safety requirement for general anesthetics and deeper sedation. The idea being that when you give drugs that obtunda patient, essentially make a patient very sleepy, you may reduce the reflex activity that protects them from potential passive regurgitation or even active regurgitation, and their ability to stop that from resulting in an aspiration pneumonia. An aspiration pneumonia as a complication is one of the worst things that can happen in anesthetics. It causes such profound problems that death is often part of the outcome, and it is avoidable by simple measures to keep patients starved. So you'd think, well, it's easy to do. Why shouldn't we do it for all patients? But do we really think it's necessary for local anesthetic techniques alone or with mild conscious sedation? Because what you have to remember is, compared with other types of surgery, any of those orthopedic, general surgical, urological operations, how likely is it that an ophthalmic procedure will risk either local anesthetic toxicity by sheer dosage of a local anesthetic in and around the eye, or emergency conversion to general anesthetic? Because those are the two principal risks that people hold in the back of their mind when they are committing to a local anesthetic technique in those other surgical specialties and still insisting on the patient being starved. I would argue that the risk of either is almost small to vanishing. And for that reason, we don't tend to starve our patients that may be coming for simple local anesthetic techniques, or what we would call mild conscious sedation. The idea is the patient still remains awake, the patient still remains cooperative, and the patient still remains communicative. They are simply given medication to give anxiolysis, a reduction in anxiety. Not to be asleep, definitely not, and that's always emphasized to them. Now, why? Why does it matter? So there are benefits to not fasting. The better experience thing may not sound like the most important thing when we're doing what is very involved surgery and we're trying to get through as many patients as possible and trying to result in as good an outcome as possible. But if it's a better experience for patients, which it is, as evidenced by randomized controlled trials again, there's less fear and anxiety. They have a lower perception to pain as the surgery proceeds, and they don't tend to have postoperative nausea and vomiting. And for that, the surgeon benefits, because the surgeon then is able to get a patient who is going to be able to lie still and follow instructions, which is probably the biggest challenge for you with patients who are fidgeting and causing disturbance during an operation. You're less likely to need sedation if you haven't fasted the patient. And by not fasting, there is no evidence that there's a greater risk of any other intraoperative complication in eye surgery. So there's special groups of patients. The diabetic patients, if we fast them and they've misinterpreted their dosing schedules, hypoglycemia can kind of be presented, and that's much more problematic. Giving them a normal intake with a normal medication keeps their blood sugars in a normal range, much, much more so. Elderly patients with dementia, who must form a really significant part of your workload, the regular schedule of eating, drinking, and going through life as they normally would protects them against confusion. To say, having a regular intake of calories also does that too. And then most importantly is that emphasis that if you're eating and drinking on the morning of surgery, you take your regular medication, unless clearly it's medication that's going to create a risk for the surgery, whether that be something like an anticoagulant that you want omitted, or a particular antihypertensive agent that can cause a profound drop in blood pressure. Those things need to be selected and stopped. But otherwise, we have an open understanding with our patients that we expect them to take all of their regular medication. And that way, you don't have that risk of losing disease control, which is often going to create a greater risk for the patient than anything during the perioperative period. Clearly, allowing patients to eat and drink normally does sometimes open the floodgates to all sorts of misinterpretation and bad behavior. And you have to be really clear that alcohol, illicit drugs are not part of this. This doesn't come into it as far as you're concerned. It's not going to help them, and it's definitely not going to help you. Oh, sorry. So further patient preparation, apart from just telling them about being nilled by mouth, we like to give them preoperative guidance, whether it's verbal or written. And what we'd like to do is to try and create a sense of what's going to happen to them. That preparation often allows them time to ask questions that are relevant, but also just to know what's expected of them. So they know the sequence of events that will happen on the day of surgery. They know the duration of waiting, intraoperative period, and also, most importantly, they know how to behave. We want them to cooperate with us and allow the surgery to happen without any difficulty. I always suggest them wear loose, comfortable clothing. It's rare now in the UK for the elderly patients that we've seen in the past who've fought in the wars and have come presented in their suit and ties. But I find it so flattering that they feel this is an important way to present themselves to the surgeon, to the operating room, to the team looking after them, because they feel that that's a respectful way to be. But it's not going to help them be comfortable. So I always say, be comfortable, take your tie off, loosen your shirt, and you will lie there more comfortably. The position's really quite important. Patients need to take on a flattish position, obviously, for the overhang microscope, but it doesn't have to be perfectly flat. And I think there are more surgeons in resource-poor countries who I've seen work much more flexibly around more angled patients, slightly higher head levels than I have in the UK. It's a real challenge in the UK for us to deal with patients who have difficulty in lying flat, either because they have breathing problems, they have some element of cardiac failure, they may have some profound reflux, they may just be profoundly obese. And these ones have to go to a select group of surgeons who are comfortable working in a semi-recumbent position. But it is possible to extend the head and make the best position possible. This is something you get to learn to do because you are skilled surgeons and you work with a team who probably help you. But remember the patient's part in this. Emphasize what they can do to adopt a position that's going to help you, because you need to be able to tell them about the risk of movement, how it can cause problems, but do this in a kind and considerate manner. We don't want to put all the fear that we can in them. We want them to be calm and cooperative. Now, pain's a tricky one because there may well be pain during the surgery, depending on the technique you use, whether you use a topical intracameral approach, whether you use blocks. And as a result, you do need to be able to give them warning that this may be part of the process. But what we often observe, and it puts a smile on the face of the anaesthetist, because you sometimes realize the surgeon unintentionally creates pain in the patient. I think the best way to deal with this is to simply say, if you feel pain, let me know, but not necessarily warn of pain at each step, because you have to be careful with the use of words. If you warn the patient they're going to feel pain, more than likely they'll feel pain because of that nocebo effect, the fact that they've heightened their awareness of what they're going to feel. So something in between has got to what's going to happen. I don't want to be teaching you things that you're probably well experienced in doing, but that's just some little words that I've kind of come to think about when I speak to new surgeons and just get them prepared for the way they talk to their patients. Now, more interaction, please. So I'm sure not all of you deal with pediatrics, but I'm sure a large proportion of you have to, because that's the nature of your practice. It's both adults and children. You don't have those niche divisions as elsewhere in the world. So think about this one. This is about a child with an upper respiratory tract infection, an URTI, sometimes referred to an URI in the US, an upper respiratory infection. A 9-year-old girl who's been previously diagnosed with congenital glaucoma presents for an urgent trabeculotomy. She had been managed up till now with medical therapy, but has shown an acute deterioration. At the time of admission, she has a persistent cough. Her parents feel that over the past few weeks, she's been feverish, coughing repeatedly, and has had a congested nose and has not been eating well. And they feel that most of her symptoms have slightly improved, but the cough still persists. I'm sure you've all been faced by something like this in your time, but looking just at the facts I presented you just now, how would you proceed? Her parents have really expressed concern as they know that general anesthetics is dangerous with a chest infection. So, do you proceed with surgery under general anesthetic as soon as possible, because that's what the surgery needs? Do you proceed with surgery under general anesthetic after 1 week, treating with antibiotics and physiotherapy in between? Do you wait for 6 weeks after the upper respiratory tract infection symptoms have settled and then proceed with general anesthetic? Or do you refer her to a large pediatric tertiary centre where the possibility of anesthetic complications can be managed? Or do you actually say, whoa, we can do this under local anesthetic. Let's proceed under local. Very few going ahead straight away there and then recognising risk and managing risk. And that's what we all do in medicine. We manage risk and we have to manage it in the way we know that is appropriate. A good split between waiting 6 weeks and another good split said sending her to a larger pediatric tertiary centre. Only very few people proceeding under local. I do think proceeding under local with a 9-year-old is super challenging. And I think it takes a very skilled set of surgeons, nurses, doctors around her to achieve that. But it's possible, but I do think it takes a very high level of skill to do that. So I'd be challenged by that. I know that for sure. So let's talk about this. What would my answer be, first of all? Again, really difficult. I found that question the hardest one of all the ones I've posed to you, because I recognize when a surgeon says to me, this can be site saving, it is absolutely incumbent on me to find a solution. My solution would have been able to go ahead with the general anesthetic on the day of surgery, despite all those risks, manage them as best I could, knowing that I have recourse to the support of some major paediatric centres in London, such as Great Ormond Street and the Evelina Children's Hospital. But I also know that you don't, wherever you might be working. So that puts me in a very privileged position. And I have to admit that being safe around a child in some of the more challenging environments is by far the most important thing, and recognizing that you may well have to compromise in the surgical intervention as a result. I believe too many children have died as a result of anesthetics going wrong rather than surgery going wrong. And that's not something that you can ignore. Anyway, let's talk. Upper respiratory tract infections, common childhood infections. Most kids get about 6 to 8 a year. Sometimes described as a common cold, involves sneezing, nasal congestion and discharge, sore throats, cough, fever, malaise, can be very vague. They are associated when given a general anesthetic in the situation of one of these being present with what's called perioperative respiratory adverse events, a complication. And that's because there is reactivity in the airways, which is much more heightened as a result of the inflammation. And the patients can suffer from laryngospasm, bronchospasm, atelectasis, collapse of their lungs, coughing, profound coughing, persistent coughing. They can get airway obstruction. They can get stridor, which suggests a partial airway obstruction. They can get breath holding, and they can get hypoxia. And in fact, laryngospasm is the most likely cause for a respiratory-induced cardiac arrest. This can be scary territory. Think about the other risk factors. So if you've got a patient with some of these features, and you've got other risk factors present, such as the fact the child has been prematurely born, child has existing asthma, comes in from an environment where there's passive smoking that's present and parents or family members smoke, or there's a history of snoring in the child, then you should be very, very, very aware that complications can be more problematic. What can you do about it? Well, in elective surgery, you can only cancel, unless it's just minor symptoms and an older child. There is no point taking a risk for what is surgery that can be done at any time. Can you use investigations to guide you? Well, they're not really that useful. Sometimes putting a SATS probe, an oxygen saturation probe on the finger, can help because it can actually guide you to recognize the fact there's a low respiratory tract infection, there's a pneumonia present. There may be depressed saturations, and that can be really helpful because that's another major warning sign that this may not be the right way forward. But here we go. If you must go ahead, what can you do? You can ensure that the child is well hydrated, so minimal starvation times as much as possible. Even where a patient's coming for general anesthetic, in my center and in my practice, we will ask the child to stay hydrated up until an hour preoperatively. So that's nil by mouth to food, 6 hours preoperatively, but continue with clear fluids, specifically water, until 1 hour preoperatively. Hydration counts for everything. If you can, also provide a humidified breathing circuit. So in whatever way, nebulized solutions of saline through a mask can help just as much as soften secretions and the mucus and help them to clear as much as they can. Of the drugs they can use, pre-op bronchodilators do help. Perhaps they stop a lot of the reactive changes further down the airway, but anticholinergics such as atropine and glycopyrrolate don't help. If you are going to do a general anesthetic, a supraglottic airway, some type of laryngeal mask airway is preferred over endotracheal tubes. Again, you have to be really sensible about making the choice. Very small children, you may not feel confident and comfortable that this is still a secure enough airway, and an endotracheal tube might be a better choice. But more often than not, if you can use a supraglottic airway, you will find that it's less stimulating and less likely to result in problems, both at induction and at emergence. And IV anesthetics always perform better than vapors. Now that's a privilege that I have. I can give all my anesthetics as IV anesthetics. Not all of you do, and I recognize that. What you can do is do a synergistic type of anesthetic, where if you're giving a vapor induction, maybe assist it with an IV dose at the time when you first form laryngoscopy or otherwise, to ensure you've got good control. And on the reverse side, when you are getting to emergence, use small doses of IV anesthetics as you essentially reduce the vapor content in the child to stop them from becoming reactive to what is essentially an airway irritant. And that way you can hopefully have a nice, smooth emergence. Very anesthetic on that last bit, because that's much more about what anesthetists do, but I wanted to share this for all the audience. I know I'm getting closer to the end, but I just want to do a couple more where I'm going to try and do something possibly even more controversial, make you think about something else in anesthetics that we do much more of here at Moorfields. So, a 29-year-old woman who's 33 weeks pregnant presents for an urgent macular detachment surgery. She will be under conventional retinopexy using cryotherapy and a scleral buckle. She has had poorly controlled glaucoma for many years. She is a high myope with an axial length of 29 millimeters. I hope you have a sense of the picture I'm trying to create for you here. So how do we proceed? She's pregnant, but we still go ahead and give her a general anesthetic. We take all the precautions we can in the center we're working in. Or we send her off to a maternity unit where they can give a general anesthetic because they have obstetric care on standby, but then that means the ophthalmic service has to be given to her there, so they'll have to move with her. Or we do this under local anesthetic. Let's not worry about a general, and we could give a peribulbar block or a retrobulbar block, knowing that there's risks of a long eye and a possible staphyloma, especially being, chronic glaucoma. Or we can use a subtenon block, acknowledging the fact that people are often concerned that these blocks aren't as efficacious or long-lasting. Or we could go for a really simple approach where we just give topical anesthesia and some oral sedation. Well, I'm glad that, well, there's a small portion who thought to do the general anaesthetic where they are. They may well have obstetric and maternity support on site, but giving general anaesthetics to pregnant patients, especially in late pregnancy for non-obstetric reasons, is one of the most fraught things. There are so many considerations and so many risks that that's quite a daring thing to do. Probably better to have it done with maternity services literally on standby, monitoring fetal behavior and being able to tell you all is well. But what's interesting is the largest group is for general anaesthetic rather than local anaesthetic. I would argue, and I would firmly suggest to you, that these surgeries can well and truly be done under local anaesthetic. And this is something we proudly do at Moorfields. We do really encourage our patients to consider local anaesthetic as a technique. Where there are risks to either themselves or an unborn child, we are very, very positive about the outcomes and benefits of doing this under local. Now, clearly, if you give any child, any unborn child, any pharmacological drugs, whether it be anaesthetic drugs or otherwise, there's a risk of tragedy. In this case, it's quite late in the pregnancy, so much less of a concern. But there are the other risks to the unborn child, where general anaesthetics can cause changes to blood pressure and all sorts of concerns related to the way that the mother is managed and risk of airway and risk of hypoxia. So there are risks related to the unborn child that we want to manage. There could be the possibility of pregnancy-induced hypertension and/or glucose intolerance that we haven't covered as yet. So those could also make managing these sort of patients very difficult. But the bottom line is there's a very serious risk with general anaesthetic in this group. Also, you need to consider when you get the patient to lie flat, which, to give a general and then start the surgery, that's what's often needed. You need to consider uterine displacement and the risk of reflux. If you don't displace the uterus, then potentially you block venous return, reduce the cardiac output, reduce perfusion to the fetus. And if you've risked failing to treat any of these because there are all these concerns going on in terms of the patient's eye, it can be problematic. So what I would like you to consider is going back and thinking about the local anaesthetic approaches and what makes you hold yourself back. What makes you think a local anaesthetic approach may not be correct? Clearly, a sharp needle block has problems, especially if you recognize that it's a long eye and the risk increases with that long eye for potential complications of perforation, where you consider that there is staphyloma present because of the glaucoma. So maybe a sharp needle block isn't the way forward, even though if that may be your most common and most comfortable technique, maybe you need to engage a new technique into your armament. And the Subtenon is a very good technique. And I'm going to re-emphasize that in the next case. Let's see if it influences your choices. So if you can take the options off for me, and I'm going to move to the next question. Thank you. Oh, sorry, I've jumped forward, and what I want you to do now, here we go. So we're going to, so there's been a slight change in consideration. More people considering about subtenons, which I'm glad about. Well, with that in mind, let's pose the last question, and I can wrap up very quickly. So this time, a 59-year-old man has suffered trauma to his left eye. He's presented 72 hours ago after the injury, and it's clear that the penetrating injury has now become infected, and he's showing signs of sepsis. He's pyrexial, he's tachycardic, and he's got a raised white cell count. He has a significant medical history. He's had ischemic heart disease for several years, and he gets shortness of breath and occasional chest pain and very little exertion. Moreover, he's experienced a past episode of a pulmonary embolus 3 months earlier, and he now takes warfarin. His current INR is just below the range that is required. They should be 3 and above, but he's at 2.9. So let's think about how we can do this. He needs to be done. This is an emergency. Surgery as early as possible. Know that GA's got risk, but just get on and do it. Start intravenous antibiotics, correct his INR, wait 24 to 48 hours before surgery, and then continue under GA with the full cardiac precautions. Or immediate surgery under local anesthetic, a peribulbar or retrobulbar block, acknowledging the risks of bleeding with a sharp needle block. Immediate surgery under local anesthetic using a Subtenon block, acknowledging the associated concerns of longevity and efficacy. or just saying surgery cannot be done safely and he should just be treated with intravenous antibiotics. So again, there's a good consideration for safety here, and treating with intravenous antibiotics with a view to the fact that he is septic seems perfectly reasonable. Even then, giving a general anesthetic, even with full cardiac precautions, will be a shaky time with this patient. I've probably nudged a few of you now to think about subtenons as opposed to a sharp needle block. Clearly, a sharp needle block with somebody with an INR of 2.9 is slightly unnerving. But again, you are very capable practitioners. You've probably done this a lot more than I have, and you probably could do things safely. Nevertheless, what I want to talk about is these patients with multiple comorbidities and eye surgery. Often you need to get help to manage their medical conditions, especially if they're on drugs that are going to cause complexity to your surgery. Anticoagulant drugs, really large and complex subject. I've had to write a policy for my own surgical teams here. And it's been a very fraught procedure because each surgical specialty has a different consideration and each medication has a different sort of consideration. There are reversal treatments if you need to put them into place, vitamin K for warfarin, or even pressurizing plasma, or even direct antagonists. There's also the use of bridging therapy if you need to keep somebody relatively anticoagulated because the risk is so high. They may have a metallic valve. So these need to be managed, but these are well out of the scope of a simple kind of eye unit. You need individuals who manage this a lot more to help you and guide you. But always be wary when there's a suggestion of sepsis present. You need to diagnose, you need to get early antibiotics, and you need to ongoing observations. And maybe you could still use tranexamic acid in a situation where there is a risk of bleeding, such as in a enucleation. But I want to wrap up this presentation. I know I'm getting to the end, and I want to just talk about subtenonal block. This is something that we are very, very enthusiastic and very vociferous about at Moorfields. It is the default technique for local anesthetic, and it has pervaded across. It is also now the default technique for Orbis, and we have tried to show in many centres around the world how it can be delivered safely and effectively. So what I want to tell you, it is reliable and effective. It does give you immobility. It does give you eyelid akinesia. This is often, if you can use hyaluronidase as part of an adjunct to the mixture of local anesthetic, dependent on that, essentially the ability of the hyaluronidase to create that permeation of the local anesthetic more deeply. But otherwise, delivering the block and waiting appropriate length of time will deliver the same effect. You do avoid the serious complications of sharp needle blocks, and you have to remember some of these can be present much later than once you give the local anesthetic. So you may feel that you've given a peribulbar block without complication, but these complications can present much later on. With the Subtenon, you can deliver large volumes. Some of my colleagues here for vitreoretinal surgery will deliver up to 15 mils into the orbital space. And you can do this very effectively with the Subtenon technique, as long as you are conscious of the potential for proptosis and filling the eye too profoundly. The other thing about Subtenons is it's very easy intraoperatively to top up the block. So a very long surgery, which might go beyond the scope of even any type of peribulbar, retrobulbar, can still be topped up as a Subtenon because there is an entry point and the Subtenon space is open. It's suitable for all types of eye surgery. Whatever you have thought of, read about on this topic, we have done every type of eye surgery here at Moorfields under this. We do strabismus surgery, we do glaucoma surgery, we do retinal surgery, we do oncology, we do enucleations under local blocks. For our pregnant patients, the local block allows us to do anything they might need. There are some cons into this, and I accept that. Some of the cons are that you need additional equipment, but this can come from the surgical set. The Moorfields forceps, the Westcott scissors, and the Spectrum can come with the surgical set if necessary, and the cannula is the only difficult thing, but you don't need to use the preformed metal cannulas, as I'll show you in a moment. And clearly there's a learning curve to when you start doing these to avoid the common complications that are minor, but are still disconcerting. You can get chemosis and you can get some subconjunctival bleeding. But just as a quick visual, that's the standard set that would be delivered to us on the left. What I tend to use is the sheath of an intravenous cannula with the needle taken out, and that avoids the trauma that the preformed metal cannula can possibly provide over the top of the eye one. But it also means that when I'm working in environments that don't necessarily have those preformed metal cannulas, I always have a delivery device that works, as long as I can borrow from the surgical set. But that's my only point of preaching about subtenons. I would emphasize how good they are and how useful they are to your armament of different techniques. Other than that, I'm now going to stop. And I'm going to say thank you very much for listening. And what we should try and do is address some of the questions and answers that have come up along the way. First question has come up. Dr. Casso Nandale, after giving the maximum tolerable retropulbar anesthesia, if the subject still complains of pain and the eye isn't akinetic, what will you do? I don't want to be facetious. One of the things I'm saying here is the subtenons does allow you to still carry on topping up. It's very hard to keep topping up a retrobulbar, principally because the risk of needle penetration continues and doesn't dissipate. Doing it more than once gives you cause for concern. It's hard for many practitioners to believe that a retrobulbar can be replicated by subtenons, but we are able to persuade people by our techniques that this is actually the case. Many doctors come to visit us from elsewhere and are surprised at what the subtenons can achieve. So that's a brief answer. Other than that, I wouldn't get myself caught in that situation because the subtenons would be my choice. There's a question from Rosa Chavez, which is in Spanish. I might need some help from that. But I'll move forward until we come back to that. What other methods to reduce preoperative and intraoperative anxiety in a patient? So definitely, I feel that what you are asking me is something I might have covered already about the preoperative preparation, about preparing the patient for the process, understanding what's going to happen, dressing them comfortably, making sure they're fed and watered. We also have a very lovely technique at our hospital where we have volunteers who come and hold the hands of patients. That human touch counts for more than anything that I can give intravenously. Other than that, though, we do use anxiolytic drugs given either intravenously or orally to our patients. That may not be present for you, and if it isn't, then I think all those other practical measures as a package will definitely help you. What's the best technique for anesthesia for preterm infants undergoing laser therapy for ROP? Shouldn't they also be fasted? How long should they fast be? Oh, fantastic question. Thank you, Idit. You have essentially presented me with one of my scariest moments in anesthesia when I was volunteering for a Mongolian flying eye hospital mission, and I was asked to exactly do what you were describing. I'm not sure if I'm giving you the best possible answer because I did something that might not feel like it's going to work, but I feel that as a technique, it can be very powerful. And that was simply, these are small infants. They're very, very susceptible to postprandial sleeping. So what we did was actually we fasted these children up to a point, but then we asked for the mother to breastfeed the child. We swaddled the child, we topicalized the child, and we held the child in our arms for the surgeon to undergo the laser. And over the course of about 5 to 10 minutes, this was adequate. Clearly, longer lasering is not going to be possible. But the two things we were able to achieve using this technique were one, laser, but two, more importantly, intravitreal injections, which the surgeons felt very unsure about, given the fact that there was no clear anesthetic. But as I said, this is a much, much more conducive way to managing premature babies who have got so many morbidities associated with them. What would you do otherwise? I think what you'd have to do is use the traditional sedative technique that you have present for those infants in their NICU or whatever setting you're in. That drug changes all the time in the UK. I wouldn't be able to tell you absolutely what is the ideal. Things that are currently being very fashionable, things like dexmedetomidine, but these are clearly not going to be available for you where you're working. So whatever you are most familiar with, knowing how it can create a state of calmness in a child just for the briefest period, and using that with topicalization and a swaddle technique, holding the child very still, can be the best way to proceed. Here's another one. Best retinal exams for aggressive and confused eye patients, especially doing, you know what? You're absolutely right. I don't know the answer to that one. I'm sorry, Eddie. That's a fantastic question. Again, I wish I could give you an answer about really difficult adult patients. Here, we'd be lucky enough, we would be able to say, right, we can give them a general anesthetic. This necessitates it. But if you're doing this regularly for many patients in a difficult environment, I can see that's just not possible. There would be some oral drug that you might be able to try, but it will be trial and error over the course of many different oral drugs until you found the one that hits the appropriate window of calming the patient for long enough for you to achieve that and what is available to you without difficulty. But that's the best answer I can give you. I'm sorry about that. So, role of remote monitoring of vitals preoperatively in patients with uncontrolled hypertension cardiac. Yes, absolutely. This is what I'm talking about primary care, where in primary care, the doctors seeing the patients are measuring these things and able to tell us what the blood pressures are and whether these are relevant to our concerns. If they're clearly running hypertension in their sort of normal state at home, they need to be treated before they do come for surgery, to the point that it's problematic and causing risk to them from end organ damage. But that's definitely what I was talking about. It all should be done by primary care ahead of us. Right. If one doesn't have proparacaine or tetracaine eye drops, is it safe to apply lignocaine topically? Yeah. I think you've got a great solution. When you said you're applying it to the conjunctival sac, I think that's probably the best thing you can do. Clearly, it's not going to cross the mucosal barrier as effectively as these other drugs like tetracaine. It's by the very nature, the chemical nature of the drug. What else could you do? Could you give a small subconj injection of lignocaine? Will that meet with what you are trying to achieve? I don't know. One thing that again, this is not going to be helpful to you because, again, it was an expensive component to what we tried here once. For strabismus surgery, we tried using lignocaine as a gel formation. But for us, it was prohibitively expensive. I don't know if that's the case with you. So the lignocaine with the gel preparation, as long as it doesn't have preservatives present in it, you can even use the stuff the urologists use. A small blob of that has a very good effect because of its period of contact on the conjunctiva and the cornea. But I don't have easy answers for you. I think you work in a very hard environment, ED. I'm very respectful of what you're trying to achieve there. Now, how safe is generalized ED for GBMBs? Yeah, I would say try and avoid GA if you can. The laser has to be super focused, super quick, and done in a much, much more sort of simplistic way. But if you do need to do a GA for them, then it's a combination of NICU doctors and anesthetic doctors. Prem babies are some of the worst candidates for general anesthetic. The risks of them are so considerable, and the risk of complication just from a simple anesthetic, what is a simple anesthetic, is profound. So that would be something you'd rather avoid if possible. So in local anesthesia, what's my preference? Without a doubt, subtenons. I would never do a retrobulbar. I feel that the risk is too considerable. Peribulbar, I can see its value, and I can see how so many people around the world do it very effectively, very usefully, and achieve a really good outcome as a result. But I do think that there should be a gentle switch towards using more subtenons, despite the consumption of equipment that you need to get your hands onto. Ideally sharing it with the surgical set, maybe even the surgeon delivering the subtenons at the outset of the procedure using their set will allow you to just do these blocks that are really, really safe, but incredibly effective. For semi-urgent cases, is it possible to defer op under GA for around 2 weeks? Very possibly. You're probably going down that slope of risk, and you're probably going to have less of a problem. The one little bit of evidence that does exist around ERTs and this whole problem of general anesthetic complications is 6 weeks in turnaround time. So if it's elective, you always say 6 weeks. But you're right, maybe waiting 2 weeks. And those interventions that I was describing, humidification and use of physiotherapy, use of antibiotics, may well also come into being effective in that 2-week period. Is the cannula safe to be used after sterilization as regards to subtenons block? Yeah, a really good question. So resource limited setting in the Horn of Africa, respect to you for even having to think about this, not even something I would ever have to think about. I feel ashamed that we throw away so much in the UK. I would think so, because essentially it is not a sharp needle. There should be no tissue retained upon it. And if it's flushed and sterilized in the same way as all the other instruments, should be perfectly fine. But why not consider intravenous cannulas, the sheath of an intravenous cannula? I know it's one less intravenous cannula in your box, but that is a very cheap and very safe way to be able to make it a single-use entity. Just a thought. Can bupivacaine added to lidocaine to increase duration of action? Absolutely. So thank you, Dr. Ashok. I wish I'd been a little bit clearer about this, but you've mainly brought it to my mind. we always use a combination. For the longer procedures, we would always give a combination of lignocaine and bupivacaine, if not just plain bupivacaine without lignocaine, just to achieve longevity of action. And if you are lucky enough to work in environments where you have the bupivacaine isomeric derivations such as ropivacaine or chiracaine, then clearly you can even go to the higher concentrations. The higher concentration of bupivacaine has been associated with toxicity around the eye, but never these other ones, ropivacaine or chiracaine. Nevertheless, at Moorfields, we only use bupivacaine. We use 0.5% bupivacaine, and we'll use that in addition to lignocaine if it's appropriate, or on its own to deliver a long-acting local anesthetic block. What do you typically use as sedation before performing these blocks? Again, good question. So if I'm simply after anxiolysis where I want a patient to be relaxed, calm, and cooperative with me, I try to use the smallest dose of one of two agents, and that would be midazolam, 1 to 2 milligrams. And my favorite drug, which I don't think everyone has access to, but I find it very useful, is alfentanil. Not fentanyl, but alfentanil. Much shorter in its presence in the body. It's essentially recited within the fat very quickly and works as a very acute onset, profound analgesic, allows you to deliver a block very happily. But whatever you are comfortable using is the right thing to use for sedation. Definitely nothing that's long acting. We've been using things like dexmedetomidine more recently, just seeing what we feel about it. We're getting access to remimazolam as well for some of the longer cases. Now, what I may have really been a bit unclear about was when I'm doing these local anesthetic techniques and much more profound surgical interventions. So if we're not talking a pregnant patient who I do literally say, I'm going to give you a block and I'm going to hold your hand, and that's how we're going to do the surgery, so we avoid any fetal interference with drugs. If it's a more elderly individual having a enucleation, I will give them local anesthetic and then I'll give them an infusion of sedation, which is a very different thing. That's much more deep sedation, much more treated like a general anesthetic. We don't necessarily do airway interventions. We let the patients breathe spontaneously, but in those cases, we may run infusions of propofol. Okay, next one. Frequently, patients present with tachycardia but have known AF or medication. Should these anesthetists be on an anesthetic supported list? Superb question. Thank you for that, whoever it was. Has caused no end of controversy where we work. Surgeons feel very uncomfortable. They feel the complications that are associated with atrial fibrillation and the lack of anyone present. The reality is it rarely happens. It's rarely a problem. But fast AF, especially somebody who's truly over 120 in atrial fibrillation, should not be ignored. Whether you do the surgery or not depends on the speed of the surgery, the need of the surgeon, all those things. I have encouraged surgeons to complete an operation despite this being present, because I recognize that if we don't do the surgery then and there, the patient may well go without surgery for months, if not a year. And I feel that the patient can be managed in that situation. But nevertheless, I will always ensure the patient's then followed up for appropriate investigation and potential management for that. We often get simple advice from our cardiologists, try a small dose of bisoprolol, 2.5 milligrams, things like that, just to try and slow them down then and there, and then allow whatever else needs to happen. But I think that one is up for discussion. I think that's one where you win your friends in the anesthetic service if you're a surgeon and you say, I would feel more comfortable if you could support me with these patients. What is the current guideline for patients with recent myocardial infarction or cerebral accident to get selective surgery under GA? There's very clear guidance on this from the Association of Anesthetists, the Royal College of Anesthetists in the UK. If you want to go online, you can find it, but it's a clear 6 months and 3 months. We would not want to go near patients who've had recent MI or CVA. So recent MI, 6 months, and we would expect them to be fully investigated for any residual complications or otherwise. For a CVA, it would be at least 3 months. And even then, when those patients come for surgery, it has to be quite pressing surgery. And the elective surgery would rather wait a year if we can. How can I now, sooner in case of needle damage to optic nerves? I'm not sure what your question is. Sorry, Dr. Marin. No, I can't work out what your question's asking me. Sorry, I'm going to move past that one. Dr. Day, what way should be chosen in case of vitreoretinal surgery? Okay, well, as a default at Moorfields, vitreoretinal surgery is done under local anesthetic block, subtenons. That's the given. Every patient will be told that's the default way of managing this surgery. Some patients will be offered sedation because clearly we know they're not going to cooperate unless they're given sedation. And then a much smaller group will be given a general anesthetic. That much smaller group are clearly infants and children. Sometimes patients with dementia, although it does seem quite fraught whether we're going to give a demented patient who's got other sort of comorbidities a general anesthetic for vitreoretinal surgery. Definitely for cataract surgery, the benefits almost without a doubt present. Vitreoretinal surgery, you could argue how much of a benefit is going to be present. If it's a true macular on detachment, yes, I would be convinced that you may well consider giving that sort of patient a general anesthetic. But no, the default answer is local anesthetic, subtenon block. Is subtenon block totally safe from retrobulbar hemorrhage? Well, incredibly good question. Again, I'm sorry you kept yourself anonymous. It's a really good question to consider. So if a patient is fully anticoagulated, would you still feel comfortable using a subtenon? I personally would, because I tend to use the cannula technique, the soft insert of an intravenous cannula. There is no metallic component to that. It cannot perforate or cause damage. You could argue that a preformed metal cannula could, if pushed hard enough, cause damage and bleeding. But the likelihood is, if you are concerned, you are going to be very careful in terms of your insertion, especially when you get periequitrol around the globe, and you are going to know that any sort of trauma may well cause bleeding. So, are there recorded events of this? I think there are 1 or 2 recorded events around the world, but in patients with such complicated medical histories that perhaps a problem was going to happen anyway. There is 1 recorded event in the UK of a patient dying at the end of a needle on subtenons, but this patient was 92 years old and had other comorbidities. So perhaps their time had come. The delivery of the subtenons was not the precipitant. What size of cannula do you use? So very good question again. Our standard preformed metal cannulas that are coming in our sets are 19 gauge preformed metal subtenons cannulas. The cannula that I use, that's a Venfon cannula, is, or an intravenous cannula sheath, is a 22 gauge. I find that to be the ideal size. Kathy, merci. Kathy, you're welcome to take this presentation. I'm sure Orbis will be happy to provide that for you. And as far as protocols, I can try and share with you. Again, do get my email from Orbis and I can try and share protocols. We don't have the best protocols, I have to say. I think like many hospitals around the world, we have established practice, but less clear protocols. We often accept what is told to us by our governing bodies, the Royal College of Anaesthetists or the Association of Anaesthetists in this country, and then we deviate a little bit, especially in diabetic control. That was an area I did not bring up, diabetic control like hypertension around the perioperative period, because I think it is a mess. I personally think we have gone for the most practical approach in our hospital, which is we recognise people who've got very high blood sugars may never get low blood sugars, and waiting for them to do so is going to defer their surgery to the point where the surgery is going to be irrelevant. So there are some guidances that exist because they're for global anaesthetic surgical care, don't always have value to us as eye doctors and eye anaesthetists. Right, any consideration to look for patients with atrial fibrillation plan for cataract op, Bocamos and LA? So, Dr. Kousas, yes, common. Maybe this is a question, a patient group I should bring up if I ever do this again, atrial fibrillation, because I can see it causes consternation. The thing about atrial fibrillation is clearly that there is a risk if the patients are in uncontrolled rate. If you are rate controlled, I would say there's no concern at all to go ahead. I would say if you're rate controlled and on some sort of novel oral anticoagulant, apixaban or otherwise, there is no concern to go ahead. Phaco surgery should not have any complications associated with bleeding, even with the subtenous bulk, where there may be some redness because of the fact that you are going to penetrate that layer in a patient who's got some level of anticoagulation. No outcome problems related to that. The problems really come where the patient's got atrial fibrillation and then has some consequence from that. They may well be precipitating ischemic changes. They may well be getting to the point where the rate is so high that unless it's corrected, they're at risk of further degenerative rhythm changes. And then it almost becomes an adult life support situation where you manage the atrial fibrillation because that's the primary thing. But do we treat atrial fibrillation ourselves? No, we never do that. because it's a chronic treatment. It's a chronic disorder and it's a chronic treatment. So we would always defer the patient for treatment if we felt that their rate was putting them at risk during the surgical period. I would say, this is more important. Go and get this solved by a cardiologist. What they will do is do investigations. They'll do echoes, look for any sort of thrombus. They'll look for precipitants of atrial fibrillation, and then they'll treat you appropriately. You know, there's a big trend in this country for ablation therapy. I'm not really got an opinion on that, but they would at least start them with medication. And as I said, doses of apixaban, edoxaban, whatever else, should not cause any reason for you not to do cataract surgery under phaco. Do you sedate patients on whom you choose the subtenon spot? Some yes, some no. It really depends on the patient. There are some patients where I think you can only give the subtenon block or any type of block and get close to the patient's eye by sedating them. You literally can't get close to their eye because they're going to clench their eye, move away, do all sorts of things. And the only way to get a block on board is to briefly sedate them. And that's when I use brief intervention sedation. What is your experience of patients on ADHD-based dementia psychosis? I wish I could say I was an expert. I'm far from. I do seem to have acquired a role in my hospital for giving general anesthetics for dementia patients. I think what that reflects is not some sort of high skill base on my pay. It more reflects the fact that I kind of recognize that as much harm as I will do with anesthetics, which I will do, my anesthetics are far from perfect. But whatever harm I will do, I am really very sure that the benefit to the surgery, especially for cataracts, is greater. With psychosis management, again, I doubt very much that I'm dealing with the patients who've got extreme psychotic conditions as you are dealing with in your situations. My patients tend to come to me very well controlled on a very good package of pharmacology, and it's not a problem because we will just be aware of the drug interactions and continue and use general anesthetic on these patients if it's appropriate. But here's the really important thing. I don't give a general anesthetic to every demented or psychotic patient because I don't think it's always necessary. I think having a real sense and recognition of the way your patient behaves by spending 10 minutes with them, talking to their relatives and understanding what is going to precipitate bad behavior, you know, agitation, disturbance or otherwise, can be more useful than not. My own mother-in-law, before she passed away, needed cataract surgery. She had profound dementia. Possibly unethically, I chose to be her anesthetist because I wanted her surgery to be done. I did not want anyone to cancel her because I knew she would have benefit, and she lived a very happy 6 months after that, being able to watch the TV. But on that occasion, I did absolutely everything I could. I gave her a small dose of intravenous sedation. I actually used propofol on that occasion because I wanted to be very short acting, and I held her head physically with my own hands so she wouldn't move while the surgery was taking place. So sometimes we can stretch ourselves as far as we need to get these patients through an operation. And especially if you're working with a surgeon who understands the lengths you are going to, they will make sure that they do what is needed and no more. And teaching surgeons the importance of doing what is needed and no more is a really important part of their surgical learning. And I have some fantastic surgeons who know they need to be in and out of the eye in the 12 minutes that a cataract operation should take most people. I think a lot of you probably do it quicker still. And I think that's to be respected because it makes a real difference to these patients. Right. Are there any concerns about HbA1c? This is going back to the diabetes and why. Dr. Han, there is a lecture in itself, but what can we say? We extrapolate the evidence from other types of studies that have looked at HbA1c and poor blood sugar control in cardiac surgery, in vascular surgery, in orthopedic surgery, and we go, oh my God, look at the problems this causes. Does it cause the same problem in ophthalmic surgery? No evidence at all. And I think we've handcuffed ourselves to try and follow the guidance that's being presented to us for other types of surgery. As much as possible, we should try and improve patients' blood sugar control before surgery. Absolutely. There's no doubt about that. But the patients who come to us with diabetic complications, who need to have their surgery because if they don't, they lose their eyesight further and their diabetic control worsens immensely, you need to make a call and say, this is as good as it gets for this patient, let's treat them. But we are extrapolating evidence. And the evidence is good evidence because it's all about microvascular changes, the risks of infection, and the risks of poor wound healing, all of which are present in these other types of surgery, but rarely present themselves in the same way in ophthalmic surgery.
Dr. Varden, allergy to local anesthetic and lidocaine is due to Hyalase? Is it dose dependent on Hyalase or due to adrenaline? Well, let's face it, there's never any allergy to adrenaline. Adrenaline is a natural endogenous substance. I'm always appalled when people tell me they're allergic to adrenaline. Do you get allergy to Hyalase? You can do. You can get some rather sort of idiosyncratic reactions to Hyalase. We've rarely seen it. We use Hyalase a considerable amount here, but that's not evidence. That is anecdotal me talking. So that's not the most useful thing to say. But I don't believe Hyalase sensitivity is as profound as probably is perceived. Do you get local anesthetic allergies to lidocaine? Yes, you do. You do indeed. And people can sometimes have this proven with skin testing and otherwise, in which case we would just switch local anesthetic and use bupivacaine instead. Rarely have we had to use things like prilocaine. But, you know, we are not that extended in our choice of local anesthetics as you might imagine we might be. And so we do just make that choice based on that. I hope that's answered your question, Dr. Varden. Dr. Day, if the effective anesthesia dissolves between the process, what should we do? I think what you're trying to say to me is if you lose the efficacy of the anesthetic, then what can we do? As I said, if it's a local anesthetic block, the subtenons is so useful because you can top it up. It's just so easy to top up. I'm always very proud if I manage to put a patient through a 3-hour operation and there's no need for a top up. But I'm not so proud that I'm going to want the patient to lie there in pain. And I'll often say to the surgeon, you can top up. This is a perfect opportunity. You put your instruments down, put some more local anesthetic in, and talk to the nurses to make sure there's something available for them to top up with, and they can do so very, very safely. Volumes are never going to be that profound. And if you think about the duration of time that's passing, even if you've given what may feel like it's close to the toxic dose of local anesthetic 2 hours ago, you should still be able to top up by a small amount later on. Which type of patients with arrhythmia who need muscle surgery, general or local? Very good question. Thank you. Not easy to answer because I don't know what arrhythmia you're worried about, but what you're tapping into is, can you do strabismus surgery under local? Most definitely you can. Very much used by us. In the time when we were bridging COVID and we were trying to avoid general anesthetics in the unknown population for COVID infection, we switched a lot of patients over to local, thinking it would be a struggle, thinking it would be difficult to do. But you can comfortably do strabismus surgery with a good subtenon block, but I'm sure you could do it with a good peribulbar block. A good global anesthetic block of the eye will achieve sufficient anesthesia. It's more likely than a general anesthetic to block the ocular cardiac reflex because you are probably blocking the afferent more than the efferent, which is what we always do. We always give something antivagal to stop the tachycardia. The bradycardia creates tachycardia. But with a local anesthetic block, you may actually block the afferent loop of that. It may even stop the actual pulling of the muscles from creating a bradycardic response. But there's a but. If you do adjustable squid surgery, whereby you are wanting to then allow the surgeon to create different tension in the muscles to adjust to visual outcomes, it's really quite difficult with the local block. It's not impossible, and we have done this as well. We have done small dose, few volumes, a few mils of lignocaine, and allowed the surgeon to proceed, and then the patient has recovered fully from the local anesthetic to do the adjustment. But there's always a question if there's some latency of paralysis around the muscles, whether the adjustment's done well. So definitely for fixed muscles strabismus surgery, it's entirely feasible. And for the patient you're describing who I might be concerned about, I would very much want to do that under local anesthetic. Undoubtedly, I'd probably use a little bit of sedation, and I'd probably use some analgesic sedation, if that makes sense to you. Drugs that have a sedative effect, but are also really profoundly analgesic, because I find that's the perfect combination for this type of patient. Dr. Kumar, in which cases will you definitely stop antiplatelet drugs before surgery? When will you stop them? When you restart therapy? Brilliant question. Are there any absolutes to this? There probably are. There probably are. Definitely not in cataract surgery, not a concern. Most often than not a concern in retinal surgery. We rarely stop these drugs for retinal surgery. Where we would is in those cases where, with a discussion with the surgeon, you'd be saying, right, you have got a large area to delaminate. This is a fragile vasculature because they're diabetic. I think it's probably a better idea for you not to have any bleeding in the eye. And that will be a condition where we would do that. Where the retinal surgeon might be doing something where they're dealing with some ocular tumor and maybe doing a biopsy, maybe again there. But these are very few things. Most of retinal surgery, the retinal detachment surgeries that we see, not at all. They wouldn't be stopped. Glaucoma surgery, tricky, really tricky. This is surface surgery. They could potentially carry on with the surgery. The worry of bleeding in glaucoma surgeons is so profound that this is a discussion you'd have to have with them. So I can clearly understand when somebody's going to put some sort of large base plate tube in and they're worried about blood scarring up the area. They will probably be using, based on the evidence of mitomycin C, some anti-scarring therapy, but blood in itself is still a problem. In reality, our surgeons often use a reasonable amount of vasoconstrictor on the eye with adrenaline and otherwise, and bleeding is less of a problem for those patients than you imagine. What next group of patients? Strabismus surgery. Again, you would think it should be a concern, but this is again another discursive event for the surgeon. More often than not, easy, essentially visualized diathermy stops you having a problem. Where I'm edging towards are the problems where the problems do arise. So our oculoplastic surgeons who work on the adnaxal territory around the eye, they'll be an absolute. They would not want antiplatelet drugs given to their patients. And we respect that, and we come to some level of compromise in working out what patients are safe for it to be stopped and what patients where it isn't. If you're doing bony work, bony decompressions and the rest of it for orbital surgery, whether it be a thyroid eye disease or something else, we accept that this is not a territory you want to be going into where there's going to be uncontrolled bleeding. It's not easy to apply some sort of hemostatic approach. Interestingly enough, the oncology surgeons I work with who will do things like radioactive plaque for brachytherapy or markers for proton beam therapy. I'm not sure if this is familiar to the audience, or enucleation, say. There, it's again up for discussion. They would prefer these drugs to be stopped, but if we would say to them that this is actually not negotiable, they could work around that. And at least one of my oncology surgeons is very good at essentially removing the eye, not with a knife cutting or a scissor cutting technique, but with essentially a metal tie. I'm trying to think of the appropriate word for it, but essentially sealing the vessels and the tissues by a cable tie. And that's a very effective way of stopping bleeding around this time. So slightly mixed answer, Dr. Kumar. We do have a policy that's out there, and we've actually followed Royal College guidance. And there was a joint party of the Royal College of Ophthalmologists and the Royal College of Anesthetists who wrote this wonderful document that we have referenced for our policy at our trust. That would be worth your finding. Is this my last and final question? What concentration of bupivacaine in which is safe for heavy or plain? So, Dr. Adimola, you are entering territory which is almost obstetric anesthesia when you talk about heavy bupivacaine. We never need to use heavy bupivacaine for the eye. We always use plain bupivacaine. We never use adrenaline-laced bupivacaine for our blocks. So, and I can say it's quite simply, we always use 0.5%. And the rationale for that is we always know which drug we're picking up. So we don't have different concentrations at our trust. We just use the one concentration. And we know that as a result, when you're doing your calculations, your volumes will reflect the mass that you're delivering. But if you are thinking about what concentrations you were using, and say you had a small child and you wanted to give a larger volume to, I would think that there's no problem in using 0.25% if you want to get a larger volume delivered, but it's unlikely. We never really use that larger volume of drugs for these local anesthetic blocks around the eye, and I think 0.5% bupivacaine works very, very well. Thank you very much.